Good morning, everyone. On behalf of my co-chair, Dr. Erin Mulvihill, and the Planning Committee, welcome to the 33rd Annual Ottawa Cardiovascular Research Day. 33rd, but our first virtual and live. So fingers crossed this goes very well today. I'm just going to go through some housekeeping issues before I'm moving on with the day. If you have any issues during the day, you can reach out to Research Services. Kelsey is online. You can also email Research Services at ottawaheart.ca, and they'll be monitoring this email throughout the day. We have a packed agenda. We'll kick off with the keynote lecture by Professor Peter Macdonald in a few minutes. Other highlights during the day to log into the Innovation Award competition is at midday. This will be in the auditorium. This award recognizes the most innovative abstract, and the presenters will spend 3 minutes pitching their projects and ideas. There is also the Trainee of the Year lecture at 12:45, and this year's Trainee of the Year is Dr. Hila, the postdoctoral fellow. And towards the end of the day, there'll be the Pfizer networking reception at 4:15, and then we'll conclude the day back at the auditorium at 4:45 with the awards ceremony. Thanks very much to our sponsors, Pfizer Canada, Axia Therapeutics, the Polk Family Foundation, and OHeart Trainee Committee. So we look forward to a great day. Before we get started, I'd like to introduce Peter Liu, Chief Scientific Officer, as well as to follow Dr. Thierry Messana, our CEO.
Merci beaucoup, Sharon. Bienvenue, mesdames et messieurs. Thanks so much for joining us on this exciting, innovative 33rd Annual Ottawa Cardiovascular Research Day, brought to you virtually through ingenuity of our co-chairs, Sharon Chin and Erin Mulvihill, and the exceptional Research Day team led by Kelsey Boger. Sharon is our clinician scientist extraordinaire who leads the Advanced Heart Failure Mechanical Circulatory Support Program here at the University of Ottawa Heart Institute at the daytime, and writing amazing papers and grants at any other time. And her can-do attitude brought from native Australia really actually is an inspiration for us all. And thanks so much for inviting Professor Peter Macdonald to be our keynote lecturer today. It's much anticipated. Erin Mulvihill is also exceptional metabolic researcher here at the Institute with special connection to diabetes. Of course, on this 100-year anniversary of discovery of insulin in Canada's special occasion as well. She's also the faculty mentor for our trainee committee, who's very energetic and whose innovation is really evident throughout today's program. The Research Day is traditionally one of the landmark events in our annual research calendar. Of course, this is an extraordinary year. The COVID-19 pandemic has upended our research since March of last year. But despite the tremendous worry we had in terms of potential our research efforts crashing, but in fact, over the past year, the productivity for our entire research community has amazingly actually improved by more than 30% from the year before, with a higher impact publications and record number of grants. Is really unbelievable. And the resilience of research community, the ingenuity in terms of problem solving, and including our trainees, is nothing but remarkable, and has been certainly an object of admiration by many communities. The Research Day program is a demonstration project of our Oracle Research Strategic Plan. This plan highlights precision medicine, big data, AI, translational research, and promoting health in diverse populations. And these themes, in fact, constitutes the major presentation blocks within the program today. And thank you so much for bringing forward some of the most exciting research in these domains. And these research and the innovation will continue as we go forward with the tremendous support from Dr. Masana, our CEO, as well as Lian Ling of the foundation to take it forward. One of the key priorities is to support our trainees. Trainees are the lifeblood of research and we're the torchbearers tomorrow's leadership. And the pandemic highlighted one of the fundamental truths in life, that is science-based decision-making and advances save lives. And from exciting scientific progress that's featured in today's program, I think we are all comforted to know that the future is in good hands. Please enjoy today's program. And now I turn over the podium to Dr. Masana, our President and CEO. Terry?
Thank you very much, Peter. Bonjour à tous. I would like first to thank the co-chairs, Sharon Shi and Erin Murray-Hill. This is a very important day for the Institute. Research Day is definitely a very different one this year. But I like to say that, again, once again, you guys have demonstrated that research is part of the DNA of the Heart Institute. I really believe it. I think that without our research, we are not the same Heart Institute. And without a vibrant research, we cannot be a great Heart Institute. And I'm very thankful to all of you for the work you have been doing in this very, very difficult last 12 months. And unfortunately, we still have a little bit more to go, but light is at the end of the tunnel when we have this 70–80% of people vaccinated. We'll be not get out of COVID completely, but we will at least resume a better life, normal life, and you guys will be able to go back to your labs, do your clinical research. But as Peter was saying, in spite of that, you have been unbelievably successful, productive. It was just amazing. I mean, we probably had the best year ever at the Heart Institute in terms of productivity, publications with impact, grants. It's just unimaginable. And this is really a testament of your hard work, resilience, and your creativity, which I think it's just very unique to the Heart Institute. But I have good news for you. The good news, of course, is that you had all your vaccination, the first shot, you get the second one in time. You'll get better, you get to your lab. And Peter alluded to the Oracle research strategy plan. I'm very pleased to tell you today that we have worked, Peter and I and others, with the foundation extremely hard. And we're going to be presenting to get approved the $25 million research plan for the next 5 years. And this is really on top of our whole cohort budget. So this is the Oracle 2.5 strategy plan with all the different points that Peter just summarized very, very quickly. There will be a lot of an emphasis on the, of course, precision medicine. This is a very important strategic direction for research at the Heart Institute. Will it be the center of excellence for precision in cardiovascular medicine? And we are very proud to do that. So I'm sure that you make a very good use of all this money. And I'm sure you'll be very excited about the competitions to get this money. There will be internal competitions. They'll be tough. You have to give your best. But it never happened before to the Heart Institute. And this is, of course, on top of all the grants and all the peer review grants that you have. So this is very, very exciting. So I will stop there. It is a very exciting day. I would like to thank, of course, the research services for the tremendous work, the dedication as well. And to finish, indeed, I'd like to thank Peter Macdonald for being here today. I'm sure his lecture will be very, very exciting. And thank you, Peter, for joining us with all the jet lag. I don't know how you manage this, but thank you for doing this, and have all a very, very great day for the Ottawa, the 33rd Ottawa Research Cardiovascular Day. Thank you.
Thank you very much, Dr. Masana and Dr. Liu. So it's with great pleasure that I now introduce our keynote lecturer, Professor Peter Macdonald. Peter is a professor of medicine in the University of New South Wales, medical director of the Heart Transplant Unit at St. Vincent's Hospital, Sydney, as well as the head of the Transplantation Research Laboratory at the Victor Chang Cardiac Research Institute. He is also a past president of the Transplantation Society of Australia and New Zealand, TZANS. His major research interests over the past 30 years have been heart failure and transplantation, with a focus on donor management and organ preservation. He has co-authored over 350 peer-reviewed manuscripts. He has been nominated 4 times for the award of Australian of the Year. And in 2015, his research into the recovery and transplantation of hearts from DCD donors was recognized by 2 prestigious awards: the New South Wales government with the New South Wales Ministerial Award for Cardiovascular Research Excellence, and by the ACT Gift of Life organization with the Terry Connolly Award for Healthcare Leadership and Innovation. In 2017, he was made a member of the Order of Australia for his contributions to cardiovascular research and medicine. So we're very excited and happy for Peter to be able to join us today. He is actually calling in from the outback in true Australian fashion. And he'll be speaking on heart transplantation from DCD donors, expanding the donor pool.
Thanks very much, Sharon, and thank you for inviting me to participate in this research day. I had a look at the program before logging on, and I think it looks like a very exciting program, and I hope I can do it justice with this talk. So I'll just share my slides, hopefully. So hopefully you can see this is my topic, which is heart transplantation from DCD donors, expanding the donor pool. And if I can advance my slides. Not sure why. So what I want to do in the talk is give you a brief overview of heart and lung transplantation in Australia. And I think that'll hopefully demonstrate why we developed an interest in DCD or heart transplantation from DCD donors, and then describe what for us was a translational pathway from the laboratory to the clinic in making this a clinical reality. And then, if time allows, discuss some of the more recent trends or learning experiences we've had from our clinical experience with DCD heart transplantation. So this slide shows you what's happened to Australia's organ donation rate, and I understand that you're seeing a similar phenomenon occurring in Canada, but for a long time we were stuck at about 10 donors per million, but you can see from about the mid to late 2000s, there's been a steady increase in our deceased organ donation rate. This is data up to 2018, so pre-COVID era, but showing with the adoption of what we've called the Spanish model, quite a marked increase in deceased organ donation activity. And this next slide shows you the number of cardiothoracic transplants occurring in Australia, starting in 1984 and up to 2015 in this data. And the thing to highlight here is the red bars, which in the era where we've seen this big increase in the deceased organ donation rate, you can see that the red bars, which are bilateral lung transplants, have basically doubled in that era, or in the early part of that era, whereas the blue bars, which are heart transplants, had changed very little. And if you look at one of the explanations for that is that the deceased organ donation pathway, and shown in the blue bars are the brain death pathway, and the red bars are the DCD pathway. And as you can see, there has been an increase in the brain death pathway. This is data up to 2014. But the big growth has really been in the DCD pathway, and this has occurred across a lot of countries, and I gather in Canada as well. And this next slide shows you the number of deceased or organs retrieved from DCD donors in Australia up to 2014. And you can see that it's been a major source of kidney donation, a major source of lung donation shown in the red, and that accounts for a large part of the growth in deceased or lung transplant activity that I referred to, and the liver and even the pancreas. The one organ that's missing from this slide is the heart. And up until 2014, the general concern was that hearts had been, in the DCD donor, are too damaged for them to be recoverable and transplantable. However, heart transplantation from DCD donors isn't new. The very first heart transplant and the few that followed thereafter by Christian Barnard were technically DCD donors. The first donor back in 1967 was undoubtedly brain dead, but brain death legislation didn't exist in 1967. And they actually waited for the heart to stop beating in the donation process. But most people who are familiar with heart transplantation will know that the donor and recipient were co-located in adjacent operating theatres. So there was a very short interval between removal of the donor heart and its implantation in the recipient. In 2008, there were 3 pediatric DCD heart transplants reported from the group in Denver. They were undertaken over a 3-year period, and all had lived for 6 months, or were alive and well 6 months after the transplant. But again, as in these early cases, the donor and recipients were co-located in adjacent operating rooms. And there was quite a bit of controversy around these cases regarding the stand down time after cessation of the circulation, which in the second and third cases was only 75 seconds. In 2009, the group from Papworth, really under Stephen Large's mentorship, reported the institution of basically ECMO after declaration of death in a DCD donor. And this involved cross-clamping the head and neck vessels and instituting what they've called thoraco-abdominal normothermic regional perfusion. Now, in Australia, the definition of circulatory death is irreversible cessation of the circulation of the blood in the body of the person. And I remember talking to intensive care colleagues after the case report came out of Papworth, one I just mentioned, and they said, look, if we tried normothermic regional perfusion in Australia, this would basically invalidate the definition of death as it's defined here, and that would be the end of DCD programs in Australia. Having said that, they were quite comfortable with the concept of removing the heart following death and then restarting it on a machine. And this process has become known as direct procurement. And this the allowance or to be able to undertake normothermic regional perfusion does vary considerably around the world, and a number of European centres have certainly adopted this, and a number of centres in the US have also recently adopted this program. Now, if you think about the two pathways, the brain death pathway, there's a severe brain injury, loss of all brain function, variable brain death sequelae that follow thereafter, but the heart is beating in the brain dead donor. So you can undertake various assessments such as echocardiography, coronary angiography if needs be, and you can make a very reliable assessment of that heart's function after the death of the individual. And we know that cold preservation has worked reasonably well in preserving these hearts, at least for up to 4 hours during recovery and retrieval. With the DCD pathway, usually, although not invariably, there's a severe brain injury, but there's some residual brain function. So this person is not dead. Death only occurs after withdrawal of life support, when the ventilator is stopped and any inotropic support is ceased. So the heart is then subjected to a period of obligatory warm ischemia, which cannot be avoided. You're never quite sure how long this duration of ischemia will be. And then at the end of the process, you have an arrested, distended heart. And the question is, will this heart ever recover again? And if it does, how are we going to preserve it? So hopefully this will work. I think it's working on my computer. But we modeled this in a pig. This is a pig heart. This is a heart beating prior to withdrawal of life support. This next frame here is after the life support has been turned off and the blood pressure in the pig has dropped to 60 systolic, which some people have used as the onset of a functional warm ischemia. You can see here the right ventricle, which is already markedly distended in this pig that's arresting. You then have a period where you have to progress to complete circulatory arrest. And then you have a mandated standoff period, which in most jurisdictions is 5 minutes, but in some countries there's anywhere up to 20 minutes. And then it's only at the end of that time that you can actually intervene, that you can apply some preservation or flush solution to try and protect this heart. You're not allowed to introduce any intervention during this process to try and alter it. So the question is, how can we modify this process? One of the things we did in this modelling process, one of the things that we found, and was also found by Chris White and colleagues working with Darren Freed in Alberta, Canada, in a similar model, was that when the ventilator's turned off, there's this early onset of quite a profound hypoxic pulmonary vasoconstriction. And one of the consequences of that is this marked RV distension, which I just showed you in the previous video. But also at the same time, this reduces filling of the left ventricle. So even though the left ventricle is ischemic, it's relatively unloaded compared to the right ventricle. And one of the implications for this in terms of the clinical translation is that the right ventricle seems to undergo a disproportionate injury during withdrawal of life support. So we thought if we're going to translate this into clinical practice, we had to be very sensitive to avoid anything that's going to stress the right ventricle. So in sort of working out how we would start a clinical program, we worked out, these are the things that we thought were important. We needed to minimize the damage during withdrawal of life support, if that's possible. We need to optimize the organ preservation during transport. And we need some way of assessing the organ viability prior to transplant so that the surgeon can be confident that when he sews this heart in, it's going to work and support the circulation. So we formulated a series of hypotheses to address each of these points, and they became basically the PhD of a very talented young surgeon, Arjun Iyer. And the hypotheses were that if we modify the composition of our flush solution, we could reduce the myocardial ischemic injury and prolong the tolerable warm ischemic time that this heart could sustain. We also hypothesized that ex vivo myocardial perfusion would provide superior preservation to static cold storage, the way we normally store and transport our hearts from brain dead donors. And finally, that ex vivo normothermic perfusion with the heart beating would enable the surgeon to assess the viability of the DCD heart prior to implantation. So this time doesn't allow me to go through each of these studies in detail, but this was the first study which we published back in 2014. And this was basically using the pig model, which I just showed you, And what we found that with porcine DCD hearts that were flushed with Celsius solution and then recovered following with normothermic perfusion, they recovered fully if the warm ischemic time was kept to 20 minutes. If it was extended to 30 minutes, there was very poor recovery. And if it was extended to 40 minutes, there was no recovery. However, if we modified our flush solution and introduced these 3 agents, which we've used in brain-dead donors, we could get complete recovery of hearts up to 30 minutes of withdrawal of life support and partial recovery at 40 minutes. So what we could show by modifying the composition of the flush solution is that we could buy 10 minutes of warm ischemic time and still get full recovery of the heart. I think the other important thing about this was that it showed that it's possible to intervene after death to protect the heart from warm ischemic injury. The next step was to take that solution and to test it in combination or comparing static cold storage with normothermic ex vivo perfusion to test our next 2 hypotheses. So what we did in this next series of experiments was to take porcine DCD hearts retrieved after 30 minutes of warm ischemia with our supplemented solution and either recovered them using normothermic ex vivo perfusion for 4 hours or using static cold storage. And to cut a long story short, if we used normothermic ex vivo perfusion and then transplanted the hearts, they all recovered. If we took these hearts and put them on ice for 4 hours, none of them recovered. So it was this combination of pharmacological post-conditioning with normothermic machine perfusion, which we thought was the pathway towards clinical translation. This shows you normothermic machine perfusion. So this is the Transmedics device, which we had begun to use back in 2012 to recover what we would call marginal hearts from marginal brain dead donors. But the basic configuration of this system is you have the aorta cannulated to a perfusion cannula with oxygenated blood running retrogradely down the aorta against a closed aortic valve. So it goes down the coronary arteries. It perfuses through to the right heart, and the right heart is shown here on the right of this. So it's then ejecting it out the pulmonary artery, and this is a cannula in the pulmonary artery, and this is deoxygenated blood returning to the oxygenator, and then it's the other thing to show here is that the open left atrium. So in this configuration, the left ventricle is beating, but it's not doing external work. That has both advantages in that it rests the heart, but disadvantages in that it makes it difficult to make a functional assessment of the heart. And the main way of assessing the viability of hearts using the Transmedics system in the art and in the pig model. And you can see that over time, over the first 3 hours in these experiments, the lactate level coming out of the heart, shown in blue, is lower than the lactate going into the heart, telling you that the heart's actually using lactate as a metabolic substrate and that it's falling over time. Now, with the human DC or human brain dead donors, the viability criteria that is Transmedics established is that the total lactate in the system was under 5 and there was evidence of extraction, and that was a viable heart. And you can see that in these 8 experiments, these are all in a pig model, 7 of these hearts all performed or demonstrated viability, but there was one heart that you can see started at a high lactate level And by 3 hours, it was generating lactate, which was telling us that it was ischemic. And this heart we would regard as non-viable. So the next step then was to take our preservation solution and our Transmedics system, which we had been using already to recover brain-dead donor hearts, to start recovering DCD hearts. Now, it wasn't simply a case of turning up at the next DCD retrieval and saying we're here to take the heart along with the lungs. Before we commenced a clinical program with the DCD donors, we had to engage all our key stakeholders, the intensive care specialists, the abdominal transplant retrieval surgeons, because we need to drain, if possible, up to 1.5 litres of donor blood before they commence infusion of any of their abdominal preservation solutions. We also obviously had to have our institutional research and ethics committee approval, notify our state Department of Health, and finally our National Organ and Tissue Authority. And that process took about 12 months to get everyone on board. There are a couple of additional considerations. Zaniparide, which we think is very important, is actually not approved for human administration. And after a lot of argument with the Transmedics people, they convinced us that we, rather than use Celsior solution, we should switch to St. Thomas's solution because Celsior is designed for prolonged cold static storage. So this is the actual solution that we've applied clinically. St. Thomas's #2 solution supplemented with EPO and GTN. And in terms of the procurement technique, we don't, the use of antemortem interventions such as administration of heparin is quite variable across Australia. In New South Wales, in my state, it's not allowed, but in Victoria it is. But we work on the assumption that antemortem heparin will not be administered to donors. So, and as I mentioned previously, no attempt is made to re-establish the circulation in the donor after death. But where there is rapid venous decompression, the blood is drained with a large bore cannula in the right atrium into a blood containing 30,000 units of heparin. And following removal of the blood, we administer our preservation solution and then explant the heart. Again, there was a process of engagement, as I mentioned, of the intensive care specialists across all the major donating hospitals across the state of New South Wales. And they're the individuals who I approached to do this. And this is the initial sort of criteria we set. And in this initial set of experiments, we said, look, we will retrieve hearts and just observe their performance on the Transmedics system. We will not attempt to transplant hearts until we're confident that they will work. And these were the initial criteria that we set: an age less than 60, no known history of structural heart disease, and so on. And I gave a presentation at one of our Sydney hospitals, and a week after that presentation, I was notified about a potential donor who was actually older than our stated upper age limit, but this was a person who unusually was fully conscious. He had relapsed Guillain-Barré syndrome and was totally locked in and had made it clear that he wanted to have withdrawal of life support. And in doing so, he wanted to donate organs for clinical benefit if possible, or research if that wasn't possible. And this person, this was back in 2013, and this person became our first human DCD retrieval. So he didn't receive antemortem heparin. Time to arrest was 16 minutes. The blood collection was a little longer than we had desired. It was 31 minutes. So this includes the time from transfer from the from ICU, where withdrawal of life support took, to get the patient into theatre. And then there was a flush put on the system. The kidneys were actually retrieved and transplanted from this donor, and we perfused this heart on the OCS system for 9 hours, and we modified the OCS system so we could undertake some working evaluation. This shows you the lactate levels. These lactate levels were started at quite a high level, but they were showing a favorable downward trend. And when we looked at the performance of the heart, it certainly wasn't normal, but it was encouraging in that you can see the cardiac output here increasing in response to increasing left atrial pressure. And this is how the heart looked on the system. This is at 3 hours of ex vivo perfusion. And if we added dobutamine to the system, you could see this heart was responding. So we knew fairly quickly, we did 2 more of these hearts, and it became pretty clear that these hearts would be viable. And the question then became, well, what happens if we have a heart that meets standard OCS criteria, a lactate less than 5, with a coronary, with evidence of lactate extraction? We approached our ethics committee, and they agreed to allow us to extend our marginal heart study from neurologically determined death to include DCD donors. But here we became much more conservative. We decided to restrict it to DCD donors less than 40 years of age, with a warm ischemic time less than 30 minutes and a viable lactate on the OCS. We recognised that if we got this wrong, we'd probably set the field back at least 10 years. So we had very conservative criteria. And this was the 4th heart that we retrieved. This was a 26-year-old male who had hung himself, sadly. He'd had a severe hypoxic brain injury, had had an echocardiogram 2 days prior to withdrawal, which had actually shown quite normal heart function. So he progressed to, he underwent withdrawal of life support, progressed quite rapidly to circulatory arrest. At that time in New South Wales, there was a mandated 2-minute standoff time. Blood was withdrawn. He had within our 30 minutes and transplanted. So this shows you the lactate profile of this donor. And you can see, as we saw in the first heart that we retrieved, initially a very high lactate level, but by 2 hours this had come down to a level that met our viability criteria. So at this point, we decided to proceed with the transplant. The recipient in this case was a very straightforward case, 58-year-old woman with a familial dilated cardiomyopathy. She had intractable class 4 heart failure with recurrent admissions for acute decompensated heart failure, but no previous cardiac surgery and a very low transpulmonary gradient, sort of reflecting our concern about minimizing any stress on the right ventricle with this process. This next slide shows you the echo, transthoracic echo on day 1 and on day 7. And the thing that's immediately obvious was that on day 1, this heart didn't look very good at all. It was quite stunned with low ejection fraction and this sort of localized area of akinesis. We decided to place this patient on ECMO support post-transplant. But as you can see, by 1 week post-transplant, this heart had dramatically transformed, and the biopsy, which was done for rejection, actually revealed normal histology with no actual, no evidence of ischemia, reperfusion injury, let alone rejection. We published our first 3 cases in the Lancet, and that was published in, that publication came out in 2015. This next slide just shows you the first 16 cases that we did, and these were the donor profiles. And as I mentioned, these were all young donors with mostly head trauma, but a number were suicide by hanging, generally low or very little in the way of inotropic support. But you can see in a number of cases, there was no echocardiography because in these particular instances, they were regarded as an ante-mortem intervention and was disallowed by the donor hospital. Now, I'm pleased to say that that really no longer occurs. We do get the echo in every DCD referral. But if you summarize the times which I talked about during withdrawal of life support, from the time of withdrawal to cessation of the circulation, in these first 16 cases, the average was 10 minutes, but the range was 4 to 16 minutes. This is the mandated observation period, which varies from state to state, but ranged from 2 to 8 minutes. And then there's the period from where withdrawal of life support takes to transfer to the operating table. And you can see that on average that took 5 minutes, but again, it ranged widely from 1 minute if the withdrawal took place in the anaesthetic bay to 8 minutes if it took place in the ICU, and that was 1 floor away from the operating theatre. And then from knife to skin to cardioplegia, which that includes on average 2 minutes to collect blood. The average there was 4 minutes, so that is very quick surgery to infuse our cardioplegia to really stop the ischemic process at that time. As I say, all these hearts were retrieved on the organ care system, and you can see this was the first heart, as I mentioned, that was on the system for just over 4 hours. And you can see a number of these hearts, these were quite distant retrievals, and they were on for almost 7 hours. But the average is about 4 hours on the system. And one of the things we've noticed is that it takes about 2 hours for the hearts to recover on the system. If you look at the recipients, I mentioned early on, we decided to only select very straightforward recipients for these patients. And you can see the first 6 recipients all had lowish transpulmonary gradient, and only one of them had previous cardiac. It basically became like normal transplant or normal transplant activity. So the case number 7 was a bi-VAD explant, another VAD explant, and more complex patients. And now there's really no difference between the selection of patients for whether the donor is a brain-dead donor or a DCD donor. In our early experience, as in the first case, we had a very high rate of ECMO use, and that's created a lot of commentary among other groups. But as in this first case, they all recovered a function over a variable time, but usually within the first 3 to 4 days. And you can see that in all these patients, they all had normal function at 1 month post-transplant. In 2019, we published our first 4 years of experience, and by that stage, we're up to 23 DCD donors. And you can see that the survival of the DCD donors here in blue is sitting about 95%. And this is at approaching 4 years post-transplant. And the red survival curve is a contemporary cohort of brain-dead donors during the same period. Now, since we started our clinical program, there's been a number of significant protocol modifications. The first has been to extend the donor age up to now less than 55 years of age. We give an additional dose of methylprednisolone and albumin when the heart is on the system, and that's basically aimed at reducing the development of edema of the heart during ex vivo perfusion. We initially commenced the onset of what we call the warm ischemic time when the ventilator was turned off. But along with other groups, we've noticed that in some patients, there's quite a period of stability before, after the ventilator is turned off, before the donor enters an agonal phase. And in 2018, we decided, again, based on our early experience, on our preclinical experience in the pig model, to set a systolic blood pressure of less than 90 as the onset of functional warm ischemia. And I'll show an example of that in a moment. Another significant modification is to add a pan antiplatelet agent, tirofiban, to the collecting bag for the blood when we collect the blood. And I'll show you the reason for that in a little while. And because we can't use the niporide, which is aimed at inactivating the sodium hydrogen exchanger, we reperfuse the blood or the heart on the system with an acidic pH, which is a simpler way, if you like, of trying to prevent activation of the sodium hydrogen exchanger. So this is a 52-year-old DCD donor. And as I mentioned, you have limited ability to assess these donors before withdrawal, before the retrieval. We're able to get an echo which looked normal on this donor. But when the heart was removed, it became clear that there was probable disease in the mid-LAD at the time of retrieval. One of the things we are able to do on the Transmedics system is to do a coronary angiogram. So you can see a catheter introduced here through a port on the system. And this is an injection down the left coronary artery. This is down the right coronary artery. These vessels looked angiographically normal. So we actually went ahead and transplanted this heart. The recipient in this case was a 67-year-old man who was getting recurrent shocks, like 5 or 6 shocks a day from his defibrillator. And he was and remains extremely grateful. I mentioned how we've changed the timing of the onset of functional warm ischemia from withdrawal of life support, where we originally took it, to when the blood pressure drops below 90 millimeters of mercury. So this was a 51-year-old female DCD donor who had an intracranial hemorrhage, and you can see at the withdrawal of life support, the systolic blood pressure here actually went through a hypertensive phase. And we've seen this in a number of DCD donors. It then fell back and remained at a stable level to this point here, which is 52 minutes after the ventilator was turned off. And it was only then that you saw this downward trajectory over the next 11 minutes to circulatory arrest. So this is what we would regard as the functional warm ischemic time, together with the time it takes then to declare death, transfer the patient to the operating room. And we've come up with a concept of what we call the asystolic warm ischemic time, which is from when the heart arrests to when we flush it in the donor. And if we can keep that under 15 minutes, these hearts generally recover very well. One of the things that we noticed, or we had experience, was with earlier in our experience, after having collected the blood, we had a number of instances where the blood just clotted in the module, and we actually sent the filters back from the module back to Transmedics. And what we basically found was that these white cell filters, which are obviously designed to filter out white cells, were clotted full of platelets. And what we've seen in a number of donors is this phenomenon of platelet aggregation. And this, in a couple of donors, we've been able to take a blood sample pre-withdrawal of life support, following withdrawal of life support, and then after the blood has been collected in a bag containing tirofiban. And what you can see in patient 1 is this process of platelet activation using a range of platelet aggregates, which is completely inhibited by tirofiban. In patient number 2, you can see very little in the way of platelet aggregation, but again, eliminating any platelet activity with this. So we think this is the sort of patient where we may have seen clotting of the system, whereas you wouldn't see it in this sort of patient. So this is variable from patient to patient, But since we started using tirofiban, we haven't seen this problem. This next slide basically summarizes where we are at the moment. So since 2013, we've attended 112 DCD retrievals, and you can see that in 21 of them, they did not progress within the time frame that we had specified to retrieve the heart. Now, since we modified our criteria and so that we take the 90 millimeters of mercury rather than when the ventilator's turned off, we've had fewer of these instances and more of these instances where the heart has progressed. We have retrieved it. The first 3 and another one have actually been purely for research, but we've retrieved 87 with the plan to transplant them. And of those, 64 have been transplanted and 23 declined. Now, I know as we've gained experience, a number of these which were declined because of inadequate recovery, we would have now accepted with our revised criteria. We've had these 5 OCS failures, 4 of them were clotting of the blood on the system. So we feel that this is a problem that we've probably hopefully solved with the tirofiban. This shows you our transplant activity at St. Vincent's going back to 2012 when we started using the Transmedics system to recover brain-dead donors, and that's shown in red. When we started our DCD program, shown in dark blue, and conventional transplant retrieval or brain-dead donors in light blue. And you can see that there's really been a very big increase in the last few years. And last year, 2020, which for us, like you, for most of the rest of the world, was the year of COVID, we thought our program would close down, but we actually did more transplants with 50 brain-dead donors and 20 DCD donors. And so far this year, up till last week at least, we've done 20 transplants and 7 have been DCD. So we're now running at about 30% of our transplant activity. And this is an updated survival figure that again shows we've had a few deaths in the DCD program, but you're still looking at an 85% 5-year survival rate for the DCD group with larger numbers. The other thing we've seen more recently is a much lower reliance on the on ECMO for early graft dysfunction. So this is the first 25 cases, and this is the second 25 cases where we only needed it in 2 cases. And that's had a big impact on ICU length of stay and hospital length of stay. This shows you where we've been to recover hearts. We're based here in Sydney from these DCD donors. The longest we've been distance has been to Darwin, which is over 3,000 kilometres from Sydney. And that's a map overlying North America, just to give you a sense of the distances that we travel to retrieve organs. It hasn't been without controversy. We're accused of killing patients at one stage. This was an ICU specialist who basically considered that if you transplant a heart from a DCD donor, then by definition that heart wasn't irreversibly ceased, and that they needed to change the law. Fortunately, that hasn't really been picked up by any media, but it was a bit worrying at the time. Now, there's a whole range of programs have now been developed to recover hearts from DCD donors. The other major group has been Papworth. They overtook us in terms of numbers, and I think they're now up to around 100 DCD transplants in their program. They've used the Normothermic regional perfusion as well as direct procurement, which is the technique that we developed. And in fact, the majority of their retrievals have been using the direct procurement technique. Liège in Belgium have developed a program where there's quite extensive antemortem cannulation and administration of heparin the use basically of an anesthetic at the time of withdrawal of life support. And then they use normothermic regional perfusion. They restart the heart and then put it into cold storage to transfer it from one hospital to another. So this is a combination of normothermic regional perfusion followed by cold storage. With Papworth, where they've used normothermic regional perfusion, they've usually then combined it with machine perfusion to transport the heart. In terms of the future, or the things that we're looking at, we've been working with a venom toxicologist, Glenn King, who's based in the University of Queensland, who's extracted a peptide from funnel web spiders, which are one of the lethal spiders we have here in Australia. And he showed in a mouse stroke model that if you administered this peptide up to 8 hours after the onset of a stroke in a mouse, you could dramatically reduce the size of the stroke and better neurological recovery. Now, this peptide acts on an acid-sensing ion channel in the brain, and we looked at this in a rat DCD model, and you can see then this is the HI1A in the red here compared to Celsius alone, and you can see quite a dramatic impact of that. And if we combine it with our other supplements, further enhancement of the recovery of that. We've also been looking at SGLT2 inhibitors, which in the heart seem to mimic the sodium hydrogen exchange inhibitors. And this is work done by Jeanette Villanueva in our group, looking at empagliflozin, showing that it has improved aortic flow recovery, again in a DCD model. So this is in conclusion, what I hope I've shown you is that hearts from selected DCD donors can be successfully transplanted with outcomes comparable to those seen with hearts transplanted from brain-dead donors. We believe that traditional static cold storage for DCD hearts retrieved by direct procurement is unsafe. We think you need the combination of a post-conditioning strategy with ex vivo normothermic perfusion to successfully utilize these hearts. And as I've just shown you in the last couple of slides, I think there's a couple of novel approaches that may help us to broaden donor heart acceptance criteria even further. There's a lot of people who've to thank and who've contributed to this work, and I'd particularly like to mention Kumar Dittal, who's the cardiac surgeon who's now based in Hyderabad in India, who's been overwhelmed by COVID. But Kumar was with us during the development of this whole program and has been instrumental in the clinical application. I mentioned the ICU specialists, and I should also mention our abdominal retrieval surgeons who allowed us into the retrieval to retrievers who enabled us to do the preclinical research to that I've just shown you in this presentation. So I'll stop there. I hope that went. I'm very happy to take questions. Hello. Are you there, Sharon?
I am, Peter. I think Kelsey has locked my video. Here we go. Thanks very much, Peter. That was excellent, and congratulations on the phenomenal translational work. Just in terms of questions, I don't see anything on the QA and no one's raised their hand, so I might just start off. So Peter, you mentioned about the delayed graft function or primary graft dysfunction in a significant proportion of patients and the need for MCS support post, but seems to have improved over time. Are there any sort of specific recipient donor factors that impact that, you look out for? You mentioned about the sensitivity of the RV to the hypoxic pulmonary vasoconstriction and making sure that they don't have any pH to begin with. But are these recipients otherwise standard recipients, or are you using specific criteria?
Yeah, they have, basically now there's no discrimination between recipients with regard to whether the donor is a brain dead donor or DCD donor. We now do VAD explants who've had pulmonary hypertension. What we found, I think, is that although we're worried about the right ventricle more so than the left ventricle, where we've had delayed graft function, it's generally been the left ventricle rather than the right ventricle which has struggled. So I think our concerns from the preclinical work weren't quite sort of met with our clinical experience. I think some of the modifications we've made have been important. Tirofiban, as I mentioned, it's a 2B3A platelet inhibitor, but I think it's having more direct effects on myocardial function. It has effects on endothelial function, and I think it may have a myocardial protective effect that goes beyond just inhibiting platelet aggregation. So although we gave it to stop the blood clotting on the system, I think hearts that have been retrieved with that seem to have a better function early on than those that were retrieved in our early lab. So we're now looking again in our pig model to look at the impact of tirofiban to see whether it actually makes a difference in terms of early graft function in these cases. I think the other thing to say is that we were in the early experience, we were really very concerned and conservative, and we had a very low threshold for ECMO implantation. So in a number of cases, they didn't even attempt to come off bypass. They just put the donor onto, or the recipient onto ECMO, and rested the heart for 24, 48 hours before even attempting to come off. Now, a lot of that, how comfortable you feel doing that with that approach really depends a lot on your intensive care staff and how comfortable they are with ECMO. And we've had a lot of ECMO experience in our brain dead donors. And I think we have as I say, particularly in our early DCD experience, we had a very low threshold for using it. And I think now, as we've got more experience, we've clearly needed it much less than we did in our early experience.
Thanks. I see Peter there with his hand up. Peter, did you want to?
Yes. Oh, congratulations. I think this is really landmark work, and obviously, change the, I think, trajectory of a cardiac transplant. And I love the use of the funnel web spider. That's a Australian specialty, which you can find live solutions out of in nature. So my two questions. I observed that while you're, doing so well in terms of the DCD population, but your brain dead transplant has also increased, so I was wondering whether this actually affected, your overall transplant kind of considerations. And I guess the other thing I was fascinated by the ability to use lactate, as kind of a readout. So does that really suggest that, the metabolic modulations down the road is where potential, opportunities might be in terms of success?
Yeah, I think, as I said, with the Transmedics system, the left ventricle's beating, but it's not working. And that, as I said, I think that has both advantages and disadvantages. And, it's great if you have a heart that's demonstrate excellent function before you put it in. And I know Darren Freed in particular from Alberta, who's worked a lot on DCD models, has developed an ex vivo perfusion system that enables you to look at function, but of the left ventricle. But that adds another level of complexity to the system, and there are more things that can go wrong, particularly when you switch from so-called Langendorf or non-working perfusion to working perfusion. People got air in the system and they've lost hearts and this sort of thing. And Transmedics, when they first developed their system, had a working module, and they took it off because of these early issues, I think. And so they then look to lactate or look to a metabolic profile, some metabolic marker of viability. And it was they that came up with the lactates, and it makes a lot of sense when you think about it. The hearts obviously become very ischemic during withdrawal of life support, and we've invariably seen very high lactates when they first put on the system. But they come down steadily over time. We also have aortic perfusion pressure, and we have coronary flow that we can measure directly on the system. But with any metabolic marker that you want to use, you need to be able to do it as a point of care measurement at the, because we take Transmedics system to the donor hospital, and we bring the system back. And that, as I say, we've been 3,000 kilometers with this system. And you need to have we're doing lactate measurements every 30 minutes on average. And we need to get the readout at the time you do the measurements. So you need a point of care assay. So there may well be other markers, other biochemical markers apart from lactate, which provide you with similar reliable information. Or similarly reliable information. But whatever it is, it needs to be something that you can hold in your hand and say, oh, this is the answer. You don't send it off to the laboratory and wait an hour or so for it to come back to tell you. Now, lactate has its own critics with some people, some groups, particularly with NRP, where they've reanimated the heart or restarted the heart in the donor, and then put it on the system. The Papworth group has said that the lactates have been very unreliable in that group of patients. But our experience is restricted to direct procurement because of the legalities around how hearts are retrieved. And in our system, we found it to be quite a reliable measure of viability. And it's not so much the absolute level, but it's the trend that's important. So if it's downtrending and it's extracting, then these hearts function well. Thank you.
Terry?
Thanks, Sharon. Peter, that was a fascinating talk. I have questions for you related to the imaging. So you showed you could actually do a coronary angiogram to one of your patients. So did you have a case where you found a significant disease where you finally either discarded it or actually did something? Maybe, I don't know, maybe a PCI on an isolated heart, or maybe a bypass. And the second question is, a long time ago when I was in Marseille, I had one of my young trainees who did a PhD on functional MRI on donor hearts, to evaluate the hearts just prior to transplantation. The protocol was to actually go harvest the heart the regular way, then get the heart the recipient was prepared, but not open, and then the heart will go through an MRI machine and be tested for functional capacity through imaging, and then be discarded or not and get transplanted or not. Do you have any thoughts about that or the experience about that?
I can tell you, when we first started with brain dead donors, we were referred one donor from interstate, and it was a 50-something-year-old donor, brain dead donor with multiple coronary risk factors. We asked them to do a coronary angiogram, and they said, oh, there's an urgent liver retrieval and we don't have time to do it. So if you want to retrieve this heart, you need to come and do it. So we went with the Transmedics system, and when the chest was open and the retrieving surgeon examined it, there was obvious severe diffuse palpable coronary disease in multiple coronary arteries. The echo was normal. The pre-donation echo was normal, but we put the heart on the system, brought it back. This was the first one we actually angiogrammed. So we took the heart to the cath lab and angiogrammed it. There was severe triple vessel disease, and we didn't use that heart. We were just too worried by the appearance, and that was the most expensive coronary angiogram that we'd ever done. And we fed this information back to the donation service in the other state, and they'd been much more compliant with getting pre-donation angiograms in brain-dead donors. So for DCD donors, coronary angiography just isn't possible because it's quite an invasive antemortem intervention, and it's just not going to happen in Australia. I think for brain-dead donors, then an angiogram done in the donor hospital, if possible, is much preferable to doing it on the system, doing it on the organ care system. In terms of assessing function in other ways, we have, I think with MRI, again, it's access to the machine and availability. MRI is a wonderful imaging technique, but again, it's the complexities of getting a heart and demonstrating function on the system while it's in this metal cage and everything like that. I don't think MRI is going to be possible, but we have thought about echo and whether we can use echo measurements, transepicardial echo measurements of right ventricular function, because the right ventricle is working in these hearts, whether we can use that as a measure of function. But I think that's still one of the limitations. The ex vivo or machine perfusion at the moment is limited ability to assess the function of the left ventricle.
Thank you.
Am I muted?
No, we can hear you. Yeah.
Oh, okay. So Peter, there's quite a few questions coming in there on the text messages. I might try to combine some of these into one. So Erin, my co-chair, was asking about translational success from the lab to clinic and providing insight on how to get buy-in from stakeholders. And related to that, question from Stuart Smith from the London program about costs for DCD versus standard DBD, and whether or not the costs associated with ECMO are covered at a state level or federal or local institutional.
Yeah. So in terms of cost, it's funded by the New South Wales state government, and so they have now incorporated the cost of the Transmedics into these retrievals. Now, the problem with that is that the state government provides a block of money to the hospital administration. And from a clinician's perspective, the hospital administration and how they divide up their money it's completely opaque. So the hospital administration always say, no, we're not getting the money to do this. Whereas the state government saying, yes, it is incorporated in the funding that they provide for retrieval of hearts. I tend to trust the state government more than our hospital administrators, but don't feed that back to them when you. So look, it is funded by the state government. it is expensive. It's like now for us with the where the US dollar is in relation to the Australian dollar, we're looking at about $50,000 per implant or per retrieval. But that's, there was a case where we retrieved a heart from, there's a case report we did where these were two brain dead donors, where one was retrieved from Perth, so 3,000 kilometres away, on ice, came back, transplanted into a young recipient who came out of the theatre on ECMO. This was a brain dead donor. Came out on ECMO, ultimately did very well, but had ECMO-related complications, spent 20 days in our ICU and 50 days in hospital. 3 days after that, we had another referral from Darwin, brain dead donor. We sent the Transmedics there, brought the recipient, in this case, spent 2 days in ICU and 2 weeks in hospital. And when we did a cost comparison of these two cases, the one retrieved on ice from Perth cost the taxpayer 250,000 Australian dollars, and the one retrieved on the Transmedics system cost about 100,000 Australian dollars, including the cost of the system. So we think in the right sort of patient, you don't need the Transmedics in every retrieval, in every brain dead retrieval, but in selected cases, it is cost effective. And if we can do multiple, if we can do enough transplants to reduce our requirement for VAD implantation, then that has huge cost implications in terms of cost savings. You know, if we can have the patient go straight from listing to transplant without needing a VAD in the meantime, then that has enormous cost benefits. So I think there are various ways of looking at this to show that although the upfront costs sound expensive, it's actually quite reasonable. And I think of TAVIs that we spend on octogenarians and the cost of those to the system compared to the cost of doing this type of transplant in someone who might be in their 40s or 50s. If you ask the average person in the street, which is the better sort of investment of money, I think I know what the answer will be.
Thanks, Peter. Always controversial when we start talking and fund allocation.
Start talking money.
Yeah. We might just do a couple more questions and then end to allow people time to get to the next session. So Dave Nagpal, also from London, has asked a question about normothermic regional perfusion. So ethical issues and ethical and legal issues aside, do you think that NRP will become the dominant model at some point in the future for DCD hearts, given the ability to assess and recover the heart in situ?
Yeah, look, I think there are clear advantages of NRP over direct procurement, and you know, the ability to, I think the ability to assess the function of the heart and also the cost of doing that. I think with NRP, with restarting the heart, you really don't need normothermic perfusion after that. And I know there's a paper under review from, so it's not yet in press, but the group from Vanderbilt they've used NRP, and they've reported on 15 cases where they instituted NRP, wean the donor off the NRP and assess donor heart function, then use cold perfusion to retrieve the heart and transport it back to their hospital, and they've had excellent outcomes. So I think in jurisdictions or states that allow NRP, I think it will become the predominant mode of retrieval of DCD hearts. In areas where it's not allowed, such as ours, we'll continue with direct procurement. So I don't see this as a competition between one technique versus the other. But I think what you'll make use of will depend on what the authorities allow.
Okay, so we might just end on this last question from Bridget, which I think should sum up sort of the title of your talk. How much do you think the donor pool could be extended from viable DCD donors in the long term? And I think related to that is, do you see any other uses for the ex vivo perfusion? Should that be standard for procurement, including DBD?
Yeah, I think so. As I tried to show in one of the last slides, 30% of our transplant activity over the last 2.5 years has been DCD donation, and I think there's a clear trend towards increasing use of the DCD pathway, and it's not being driven by us, it's being driven by the intensivists. And I think my sense is that they prefer that as a pathway. And one of the sort of paradoxes is that we as health professionals feel very comfortable with brain death as a concept, but for the family of someone who's brain dead in an ICU, it's a completely foreign concept. If you look at the DCD pathway, the family of that individual are in no doubt that that person has died once everything's been turned off and everything's stopped. But we as health professionals agonize over whether we waited long enough after everything stopped for that person to be dead. So there's a bit of a paradox there. But I think DCD is becoming more prevalent. I'm not sure what the current percentage is in Canada, but I think I gather it is increasing in activity there as it has been in Australia. I know in Papworth, I think about 40 to 45% of their transplant activity now is DCD, heart transplant activity. So I see it becoming an increasing activity globally. In terms of machine perfusion, I don't think you need it for standard criteria brain dead donors, but I think there are marginal donors, brain dead donors, where it is valuable. But having said that, we've now got cold perfusion. So the ex vivo cold perfusion device, we're about to start a multi-center clinical trial of that in Australia for donors with an anticipated long cold ischemic time of sort of 6 hours or more. So that trial is about to get underway in Australia. So I think cold perfusion is the next kid off the block, so to speak, and that will probably also find a role with DCD in the future.
Thank you, Peter. We certainly hope that DCD for hearts will eventually be able to happen here. It's not a good time with COVID, but perhaps in the near future. So thank you very, very much for speaking with us. That's truly groundbreaking translational science, and for sharing with us your clinical experience. I think that will be very, very helpful as we continue work on establishing a DCD program at our center. There are a few more questions. If we'll see if we can sort of respond to them in text, although I'm not sure that that's possible. But I'll say thank you again and close the session to allow people to move on to the next and allow you to get some sleep.
Thank you. Thanks, Sharon.
Thank you.
Thanks, Peter and Thierry. And,
yeah, thank you so much. Fantastic, fantastic talk.
All right, thank you. All right, if there are any questions,
Yeah, Peter, so take a look at the, can you see the Q&A?
I can, yeah.
Yeah, okay, I think you can actually type answers to them. So I think Kelsey removed the ones that we were able to do. There's just there's only 3 left. That's not too bad. Do you see them?
Yeah, look, I think, yeah, one of them relates to the funnel web spider venom and SGLT2 inhibitors.
Yeah.
So we are in the process of looking at both of them in the pig model. And we think, I think the spider venom is, it acts on an acid sensing ion channel. And that activation of that by ischemia activates a cell death pathway called necroptosis. And HI1A just blocks that pathway. So I think that's a very, promising strategy. And how I see that is that we may well be able to extend, you know, I said a functional warm ischemic time of 30 minutes. We may be able to take that up to 60 minutes with an effective solution and still get a fully recovered heart using these sort of further modifications to our flush solution. So that's where I see the future of that, and maybe empagliflozin in combination with it. In terms of, that's a question for you, Sharon. Is there anything?
From Rob. So how are we doing with DCD? Not very well. We haven't started. Is there anything from Dr. Macdonald's experience that we are not doing that we should be? Are the laws and protocols similar in Canada? As I haven't been directly involved with the working group for DCD in the province, I know that they are ready to start, and have they been, it's being rolled out sort of at a provincial level, but primarily led by the Toronto group, who have been able to access the Transmedics, which is the ex vivo perfusion machine that is essential. And also have some experience in terms of research. There's also training required to procure the organ and place it on the rig. I think that some of our surgeons have been trained to do that, but it just hasn't started. In terms of the laws, I was interested to see, Peter, that you were able to just change the systolic pressure cutoff. So did that require any input from authorities, or it was okay to change it from 60 to 90?
Oh, look, no, that was our decision, and that doesn't affect the declaration of death process. It just is a reflection of the time that we think is important for the heart when it starts ischemic. So the whole process of withdrawal of life support and declaration of death occurs exactly the same, regardless of when we think the onset of ischemia occurs. In our own experience, what we've found is that the key time interval for us, we think, is the time from asystole, from circulatory arrest to flush. So it's that's what we've called the asystolic warm ischemic time. And if that time is more than 15 minutes, then we expect this heart will struggle. But if it's less than that, then the hearts generally recover very well. So that seems to be the more important time than, say, that when the blood pressure hits 90 and keeps going down. But this is an evolving sort of area. I mean, we're learning as we go still.
Yeah. And I think for us, cost is a big thing. I saw in the flow diagram that you had there about how many have been done, that it's roughly about, there's 100 and odd donors assessed and 60 that were transplanted, so roughly about 50%. So there's also the costs associated with the retrieval and assessment of those other 50%, and not just the ones that go through the transplant successfully as well, I suppose.
Yeah, that's right. These are the hidden costs when you send a team out, and usually the team are retrieving the lungs as well. So yeah, even if they don't retrieve the heart, then at least they're coming back with an organ that they're going to transplant. Mm-hmm. It's not always the case, but it's usually the case.
Mm-hmm. And just for our London and Toronto colleagues, in terms of the retrieval, well, actually, it may not be directly relevant because Sydney's the only transplant program in the state. But it is the retrieval group centre based. It's not sort of shared amongst a group, let's say with Queensland and Melbourne.
No.
Yeah.
So all the other programs, or the Perth and Queensland have the Transmedics system, but Melbourne doesn't. Melbourne have sort of led with this cold perfusion system. Mm-hmm. So they've been working on that. So they don't have the Transmedics system. So in Australia, we're still the only program that does DCD hearts. Mm-hmm. And we don't mind it because we've got an open field.
Yeah.
But it's, you know, we're sort of waiting for the other programs to start. And Melbourne being Melbourne, they want to do it their way, sort of thing, you know. But with cold perfusion, the limitation with cold perfusion is that you've got an arrested heart, and so you still, I think it'll work well for brain dead donors, but for DCDs, it's you're going to need some parameter that tells you that this heart's going to work okay. And if it's a directly procured heart, it's going to be difficult with cold perfusion. If you've got NRP and then put it on cold perfusion, then that's probably okay.
Okay, I think we made it through the questions. There was just one question about Zaniperide, but I don't think you're using it. Was what you said.
Yeah, no, it's not actually approved, and we're not using it. As I mentioned, if you reperfuse with an acidic solution or blood, then that will reduce the activation of the sodium hydrogen exchanger, which is what Zaniperide is blocking. So that's sort of like the poor man's Zaniperide. Mm-hmm. But we think the HI1A and the SGLT2 inhibitors will actually have a similar action to Zaniperide. Mm-hmm. So we've got other ways of getting around it.
Okay. All right. I think we got through those questions, and I think people are slowly signing off to go to the next portion. Thanks so much, Peter. By my calculation, it's 10:05.
11:05.
11.
Yes.
Right.
Bedtime.
Yes, definitely bedtime.
Right.
6-hour drive. Okay.
Good to catch up again, and yeah, look forward to seeing you soon.
You too.
Okay.
Thank you. Thank you very much, Professor Macdonald.
Thank you, Kelsey. Okay. Bye.
Thank you. Bye.